Hi, my name is Mandy Brady, and I'm the patient care manager for our C2 ambulatory surgery area as well as our PACU here at Lakeland Regional. The reason behind our poster presentation titled The Sweet Spot Glucose Management for Safer Surgeries was that we identified the need for a more standardized approach to glucose management within our surgical patient population. Only our diabetic patients were having their blood glucose levels checked prior to surgery, and not all of our patients had an A1C result available preoperatively, which led to the concern that we may be missing some patients who were undiagnosed diabetics. Additionally, when patients presented with elevated glucose levels greater than 200, the orders for interventions varied depending on which anesthesia provider was contacted. We realized that this inconsistency in treatment did not provide optimal glycemic control, putting our patients at increased risk of surgical site infections. Some background on this project: surgical site infections related to perioperative hyperglycemia may lead to various adverse postoperative complications. Some of these complications can include increased length of stay, rehospitalization rates, healthcare costs, and increased mortality rates. While it is widely known that diabetes mellitus predisposes patients to infection, perioperative hyperglycemia in non-diabetic patients has also been shown to pose an even greater risk for negative outcomes. Elevated hemoglobin A1C levels are recognized as a contributing factor in the development of surgical site infections, while postoperative glucose levels have been identified as the sole significant predictor of an SSI. Our objectives for this project: identify surgical patients at greater risk for perioperative hyperglycemia by enhancing our preoperative screening measures and criteria, optimize patients with hemoglobin A1Cs greater than 8 prior to proceeding with surgery when appropriate, maintain tighter glycemic control on patients presenting with elevated glucose levels whose surgeries will last greater than 4 hours or are having a cardiovascular or neurosurgical procedure, and also decrease the frequency of SSIs where hyperglycemia was a factor. Some of our methods of implementation: we assembled a multidisciplinary team including members from clinical quality, pharmacy, informatics, anesthesia, infection prevention, and our nursing teams to identify the patient populations who would benefit most from the use of a more stringent glucose management protocol. We wanted to develop a care pathway algorithm and also update our existing order set. The algorithm created provides a systematic approach to the management of elevated A1Cs and perioperative glucose levels. We also held multiple Q&A sessions with our team members to allow for questions and concerns regarding how the algorithm would affect workflow. We developed a standard work to outline the workflow as well. We also felt it was important to educate our team members on the why behind this project to encourage team compliance and help with buy-in. I'll now review the algorithm from start to finish. This begins in the preoperative office visit. We have asked the providers to identify patients with diabetes, patients who are greater than 35 years of age or have a BMI over 30, and complete a hemoglobin A1C preoperatively if it has not been done in the last 3 months. If this hemoglobin A1C is greater than 8, we ask that they would postpone surgery if possible to improve glycemic control. If that is not possible, we have asked the providers to provide documentation as to why the risks of postponing outweigh the benefits of optimization. The morning of surgery, when the patient arrives to us, if the hemoglobin A1C is greater than 6.5, they have a history of diabetes, or their BMI is greater than 30, or they're over the age of 35, we will complete an AccuCheck. If that AccuCheck shows a level of greater than 300, again the question will be asked: do we cancel the surgery, or do we need to proceed if the risks outweigh the benefits? If that blood glucose is between 181 and 300, and the procedure duration is greater than 4 hours or is a CV or neuro procedure, they will be started on an insulin drip. If the blood glucose level is between 150 and less than 180, we will initiate our subcutaneous insulin sliding scale. At that point, the patient would proceed to the OR with anesthesia managing the glucose intraoperatively and titrating the drip as needed. Once the patient arrives to PACU, the PACU team will obtain a blood glucose level if the last result was greater than 1 hour ago. If that patient is on an insulin drip, we will follow the insulin drip nomogram to titrate and manage. If the patient has 2 blood sugars less than 180 consecutively, we are able to discontinue the insulin drip at that point. If the patient is not on an insulin drip, the team will follow the subcutaneous insulin sliding scale. Patients that are inpatients will then proceed to their next point of care and will continue on whatever diabetic management regimen the provider decides upon.